Welcome to the Feeling Good Podcast. Hello, I am your host, Fabrice Nye, and joining me here in the Murrieta Studios is the creator of the T.E.A.M model, Dr. David Burns. Hi, David.
Hi, Fabrice. Good to see you.
Oh, good to see you too. Yes, it's a pleasure. So what are we going to talk about today? Last time we gave kind of an overview of the T.E.A.M model and why you developed that.
How it evolved from cognitive behavior therapy to address some of the shortcomings. CBT was fabulous and did a lot. There's been more research on it probably than any form of psychotherapy in history. But it works for many people, but not everybody. And finding out why, the answer why is that, that's what led to the development of T.E.A.M therapy.
So, I think that we may want to be a little bit more specific about the various components. So what are we going to talk about today?
Well, we'll go over the T equals testing. In the last podcast, we mentioned T is testing, E is empathy, A is agenda setting, M is methods.
Right.
And this is the approximate linear sequence that you do things in a therapy session.
Okay.
And so you start out with testing. So we'll talk a little about the testing today. And to some listeners, it may seem, oh gosh, testing, measurement, that's boring. I'm not interested in that. And when I've given this segment in workshops, I often title it measurement, a boring topic with exciting implications. And the testing we're going to talk about has the potential not only to transform the clinical work of any therapist, all therapists who are listening to this podcast, it also has the potential to transform the field of psychotherapy from competing schools of therapy into the new data-driven science of psychotherapy.
Now that sounds a little bit unusual to me because I've done a lot of testing, as you may call it, what I would call assessments, where I give people a battery of tests like the MMPI-2 and things like this, just to kind of get a diagnosis or really see whether there's some personality issues or trauma issues or what have you. But typically this is kind of like something I do up front, and then I don't worry about it too much, except if something else changes. So how is that different in your model?
Well, I think it's important to do assessment at intake before you begin actually clinical work with the person. And I use and have developed over the past 10 years at Stanford something called the Easy Diagnostic System, which is a survey that patients can take on their own in the waiting room or at home. So it takes no time for the therapist. And it kind of automatically diagnoses as not present, probably present, possibly present, or definitely present, 50 or 60 of the most common DSM diagnoses.
Yeah, that's the kind of testing that seems familiar to me.
Right. And I'm no big fan of the DSM, but I've always felt a kind of medical legal responsibility to assign the correct diagnoses at intake. So you go over the patient's completed survey in a session. It takes 5 to 7 minutes. And you just tick off on the diagnostic summary sheet any diagnoses that are possible or definite. And if they're definite, you can see from the patient's score if it's mild, moderate, or severe.
Right.
But some therapists who hear this podcast will find that interesting and exciting. So you don't have to do a long diagnostic clinical history. Others will say, I'm not interested in DSM at all, and I say, God bless you if that's where you're at.
Yeah.
But the most important part of the testing is what we do at every single therapy session. Beck showed, at the beginning and end, I should say, of every therapy session, Beck showed in 1964 that you could measure depression for the first time with his Beck Depression Inventory. And that was revolutionary at the time because clinicians weren't used to thinking in quantitative ways. Someone was depressed or they weren't. And all of a sudden we had a test that could measure exactly how depressed the patient was. And I used to use the old Beck Depression Inventory when I started in clinical practice, and I made it my policy that I would never in my life see a patient without at least one psychological test at every session. And so I'd have them fill out the Beck Depression Inventory between sessions, and then they'd hand it to me at the start of the session. They'd take it at home, and I'd look at the score, and I'd put the number in the chart, and I could see if I was making progress or not. Initially, I was kind of skeptical, thinking that the Beck test would be better than nothing, but it wouldn't be very good, and that I had this idea, the way I was trained, to think that I was the expert. I know how patients are feeling. After using it for a month or two, it began to dawn on me that patients were tremendously accurate and knowledgeable about how they were feeling, and that those scores were highly, highly accurate, and that my own perceptions were often way off base.
Now, that was kind of a discovery for you, but it sounded like you made the decision to always use that index even before you made that discovery. What led you to doing that?
Oh, well, it was because I had started out as a researcher. We had a depression research unit at the VA hospital, and we had to publish articles for scientific journals about depression and the chemical imbalance theory and all of that. And so we had to know how depressed our patients were. And so we used to test them every day with the old Hamilton rating scale for depression, which is an interview that takes about 15 minutes, and it's a terrible test that should never be used for anything. It's so ill-conceived, and drug companies still use it for research, and it blows my mind because that they would do that. But at any rate, it was time-consuming, but at least it gave us some feel. It had some validity to how depressed patients were, and then we could publish articles on what was affecting or not affecting depression severity. And so I was used to doing that from my research days, and when I went into clinical practice, I thought, in a way, every patient I see can be a little research study, so I can begin to find out what's helping them and not helping them. And that was one of the things that really sold me on cognitive therapy initially, that I had a lot of patients who I was stuck with, and I could see that their depression scores weren't changing. And then I used what was in those days, in the middle to late 1970s, the newly emerging cognitive therapy techniques I learned from Beck and techniques I created, and began to see changes in many patients. And that was extremely eye-opening for me, and I began to see, hey, there's ways you can work with patients that are effective and ways that are not effective. And then over the years, I saw the shortcomings in the Beck test, not the least of which is, we used to be able to use it for free. It was in the public domain.
Right.
And then one day I got a letter in the mail, if you use this test without paying $1.50 royalty, you're going to have something like a $10,000 fine or something like that.
I see.
And it was very, very disturbing. And at the time, I was also using the Hopkins Symptom Checklist 90 with my patients, which was a kind of a research tool that you could use for free. And then that one got sold, and they wanted, $1 or $2 every time you gave it. And I used to see 70 patients a week, and I started counting up all the costs of using these tests and came to more than $10,000 a year.
Yeah.
And I thought, I'll bet we could create some much better tests. These tests aren't even very good. And then we could use tests to have really beautiful tools to assess patient progress. And so what we have come up with is little 5-item scales that have reliabilities and validities in the mid-90s, as opposed to, the Beck test has about a 65% reliability, and validity is below that.
So you're saying that you developed a scale of your own that is better than
much
Beck?
better, yeah. And there's I've developed several depression surveys, but what we've discovered is a 5-item survey will give you all the information that you need, and patients can fill it out and complete it and interpret the score in less than 15 seconds. And so now the way it's evolved, the system we're using now, I think, is state-of-the-art of measurement. Is, let's say I'm working with you, I would tell you to come in 5 minutes early. If you have a 2 o'clock session, come at 5 minutes before 2. And then in the waiting room, you'll find a clipboard and, a stack of what I call the brief mood survey. And you fill it out based on how you're feeling at this moment in the waiting room.
Okay.
And it includes a brief depression test, a suicidal urges test, anxiety test, anger test, and then a couple others that you can use if you want a relationship satisfaction, say you're having trouble in your marriage or your intimate partner. And there's also a positive emotions test. And then when the patient and it takes 30 seconds for the patient to fill this out, and then they hand it to me at the beginning of the session, and I can see exactly how the patient is feeling.
Well, I'm beginning to have some wonderings here about. Okay, well, why don't you just ask the patient when they come in and say, how are you doing today?
Well, that's what we
seems a little bit warmer than the cold, questionnaire.
Yeah, that's one of the paradoxes. Is you think a test is kind of cold and indifferent, but it actually creates much more warmth in the therapeutic relationship, because a person can be looking totally happy and have you laughing and say they're feeling great, but when they fill out the test, that person might be as severely depressed as someone in an inpatient unit getting electroconvulsive therapy. The therapist's capacity to judge how patients feel is very inaccurate. I did a study at Stanford when I was validating the easy diagnostic system, and I had experts sit down with roughly 170 newly admitted inpatients, and they interviewed the patients for 2 to 3 to 4 hours about how the patients were feeling. How depressed are you? How anxious are you? And this was to validate the easy diagnostic system, so they were trying to assign like major depressive disorder, borderline personality disorder, all this kind of stuff. And then I had a twist to the study that the participants were not aware of, that what the purpose was. But at the end of this diagnostic interview, I had the patient and the interviewer turn their chairs with backs to each other and then fill out my brief mood survey. So based on how are you feeling at this moment.
Right.
So the patients are saying, here's how depressed I am, how suicidal, how angry, how anxious.
Yeah.
And the interviewers filled out the same scale, guessing the patient's answers based on an intensive, emotion-focused interview.
And the interview was actually asking them what their feelings were, their experiences, and so on.
Yeah, that's all they were asking about.
Right. So they should know what was going on with the patient, right?
Absolutely. That's what you'd think. And also, I asked the patients to rate the interviewer on how warm and empathic, how trustworthy, that type of thing. That was an empathy scale. And also how helpful was this interview. So
you had the patient fill out the mood survey, which is about themselves, and then you had them fill out evaluation that's about the therapist.
Yeah,
okay.
And the therapist also rated how warm they thought they were, how helpful they thought they were.
So the therapist rated themselves.
Yeah, and we're guessing how the patient would rate them, how you came across to this patient. And then it was just simple to see what is the accuracy of these experts. Because if you look at the correlation and take the square of the correlation, say between the patient's reported depression and the expert's perception of the depression, let's say if the correlation is 0.9, that's an 80%, 9 times 9 is 81, that's 81% accurate.
Right.
Well, the shocking thing, in workshops, I could ask the people right now, like, how accurate do you think these experts were? How accurate do you think you are? Do you think it's 75 to 100%? Do you think it's 50? Your accuracy is 50 to 75%? Do you think your accuracy is 25 to 50%? Below 25%?
Okay.
And most people, when I present this in workshops, and the hands go up, they think they're 50 to 75%. They're cautiously optimistic.
They're pretty on track as to how their patient is doing.
And some of the skeptics will say, maybe it's only 25 to 50%.
Yeah.
But the actual results, everything came out under 10%.
Oh, like almost close to zero, right?
Yeah, there was almost nothing that the experts got right. The accuracy on detecting changes in the patient's depression, say from the start to the end of the interview, was 3% accuracy. The ability to detect anger was 0%. Suicidal urges was 0%.
And when did you do that?
Oh, about 2 or 3 years ago when I was...
so recently.
Yeah, yeah. Uh-huh.
And how many, what was the size of your sample?
Well, in the total study, there were 170 newly admitted inpatients, but for this phase of the study, we had about 50% of them. There were about 75 or 85 patients in that study.
And how many clinicians?
Oh, I'm trying to remember. There was probably 5 or 6 or 7, something like that.
Maybe those 5 or 6 were particularly bad.
Well, that's one can hope. But then we've also done the same study informally in the Tuesday training group at Stanford, and asking people in clinical practice to repeat the experiment with your own patients if you've never used these scales, and they also report that they don't get it right. And I can give you an example of just how off we can be. But why are we doing this? Then at the end of the session, you see we have the patient take the test again in the waiting room before they go home.
Right. And
leave it for the therapist. And they also rate you on empathy. So if you're a clinician, you can see for the first time how much improvement did the patient have in this session.
Yeah.
How empathic were you? Just to give you just an example that happened this Tuesday, we did consultation in the Stanford training group, and we have our trainees rate us just as I have patients rate me at every single session.
Okay.
And we did a consultation, and one of the trainees was stuck with a couple she's trying to treat. And as you know, troubled couples can bash each other's brains in, and you try to help them with different techniques, and they just sabotage the techniques and attack each other. And she was very disturbed and felt like a failure because she was stuck with this couple. And we had a wonderful consultation, and she felt inadequate, and she cried, and we turned that around for her, and she was laughing at the end and gave her fantastic feedback on why she was stuck with this couple. And then at the end, they rate the evening, and the ratings, everyone in the group was just like sky high. It was a fantastic evening. It was great to see. But she rated it, the helpfulness, as not the greatest.
Okay.
And it just blew my mind because I thought, wow, what a fantastic consultation that was. She got what she needed, but she hadn't. On the personal level, she thought it was fabulous. Her depression disappeared, and her anxiety and sense of inadequacy.
But she still didn't know what to do with her couple.
Yeah, and I didn't realize that. I thought we'd made it, crystal clear. And then I've had the same thing happen, and then that's information I never would have had. And so even as a teacher, then I can go back there and say, wow, it sounds like you didn't get what you needed. Let's talk further. And it's the same thing clinically. It blows your mind, the information you get. And the practical thing that I'm driving at here is, if you want to be a great therapist, you've got to know how you're coming across to your patients and use your patients' measurements to guide the therapy, and your patients will become your best teachers. But it's shocking because you find out stuff that will be very disturbing to you. And I can give you an example of where I missed in a negative way and in a positive way where I totally miscalculated.
Yeah, I'd love to hear that.
I'm on the voluntary faculty in the Department of Psychiatry at Stanford. Mm-hmm. So I volunteer a certain amount of teaching and other things to help out in the department every year.
Yeah.
And one of the things I did was to create the cognitive therapy daily group program in the inpatient unit, because it was all psychopharmacology and electroconvulsive therapy, and there wasn't, a lot of psychotherapy going on. And after I created the program, I went in once a week to kind of direct the groups and teach the psychologist who was running them and the nurses and, make sure it's working with this very, very difficult inpatients, suicidal and whatnot. Well, this one day, a woman at the beginning, I get their moods. I have them take the brief mood survey. It takes 30 seconds, and then I can empathize with each one. And this one woman had severe on depression and suicidal urges and anxiety and anger in all of the categories.
Right, so she was way up there.
Yeah, and she had the negative thought that she was a worthless human being, so she should commit suicide. And I asked in the group, how many of you have that? And all the hands went up. I said, well, let's work on this thing today. So everyone was excited about that. So I worked with her on her negative thoughts and used powerful techniques, externalization of voices and various things. And I could see that we just knocked the ball out of the park and that she just lived me, and her symptoms all went to zero by the end of the session. I thought, boy, this is something I can talk about in a workshop, how powerful these techniques are, even for the most severe of the most severe. And at the end, then
And you knew that from testing her?
Well, I had tested her at the beginning, but that was my feeling in working with her. Like, she was laughing and happy at the end, and it was like it was this big celebration. I'd worked this miracle on the inpatient unit. And then at the end, then now fill out how depressed are you, how anxious are you, etc. So we did it again. And then they leave, and they turn them in. And I couldn't wait to get her ratings.
So you wait until your patients are gone before you look at the ratings?
But in this case, they filled them out right in the room.
Yeah.
And then they handed it to me as they walked out. So when she handed hers to me, I could look at it.
Yeah.
And she was still 10 feet away, 5 feet away from me.
Yeah.
And I was shocked because she had put the highest symptoms humanly possible. She had put extreme now on depression.
So when it went up?
It went up. It was the opposite of what I had thought. And her scores were the highest, the worst a human being can have. Like I'm going to commit suicide today. I'm hopelessly depressed. I'm totally worthless. I'm filled with rage. I'm panicky. And then on the back, they turn it over and rate you on empathy and helpfulness. And she gave the lowest possible empathy and helpfulness ratings. The empathy scores goes from 0 to 20.
Essentially, she's telling you failed, even though you thought you did.
But it was worse than that, because on our empathy scale, Hitler could at least get a 7 out of 20. And she gave me a 0. I've never seen anything anywhere close to 0. So I said to her, Marilyn, goodness, you filled this out incorrectly. And it's easy to get confused when you fill out these tests.
Oh, you thought she had flipped it over.
Yeah. I thought you'd want to put all zeros on the mood and all perfects on the empathy.
Like, I did so great. What?
Yeah, and I said, would you correct this before you go? This is a research study, and we don't want to foul up the database. And she looked at it, and she said, Doctor, there's no mistake here. And I said, what? What are you talking about? We had a fantastic session just now. And she said, well, good for you, maybe. And I said, what are you talking about? And she said, well, when you said blah, 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 it really hurt my feelings. And I had no idea that had happened. She had lost her husband and her job in the same week.
Yeah.
She was fired, and her husband moved out and said he was going to get divorced. And I had made this statement, we measure our self-esteem on our being loved, and being productive.
Okay.
And so what you had was kind of like a double whammy, and I can imagine that your suffering is just unbearable. Well, when I used the expression double whammy, she thought I was making fun of her.
Oh.
And I had no idea. And so we sat down and talked that through, and she was very gracious and was able then to connect. But that shows an extreme example of how off the therapist's perceptions can be. And therapists listening to this probably don't believe what I'm saying, that your perceptions will be this off also. In many, if not most cases, you think you know how your patients feel, but you don't. And then you can make the opposite mistake as well. Can I give you an example of that?
Yeah, I'd love to hear that.
The next week I went into Stanford, and there was a woman. I was trying to find out who wanted help, so I gave them the brief mood survey, and this woman scored the highest in every mood category. She had just been transferred from the intensive care unit where she'd made a nearly successful suicide attempt. And then when she was medically stable, they sent her to the locked unit, actually, of the inpatient hospital, and she was in the therapy group. And so I was looking at people's scores, and I said, boy, your scores are really high. I don't know, maybe that's something we could work on in the group today. Tell me a little about yourself. And she says, well, I have borderline personality disorder, and this is my 8th suicide attempt. And the next time it's going to be a completed suicide.
Right.
I'm not going to fail at this again. And she went on to explain that she was an intravenous amphetamine addict, and she was in rehab in some kind of treatment facility, and she relapsed and used amphetamines, and so they threatened to kick her out of the program. So she said she retaliated by making a suicide attempt. And I asked her about her negative thoughts, and just like the woman the week before, she had a thought like, I'm a worthless piece of SH, and I should kill myself. Life is not worth living. And I said, well, I don't know. I said, again, how many of you have this thought in the group? And all the hands went up. I said, well, maybe we could work together. You told me you've only had psychopharmacology and supportive therapy, where the therapist listens. But I don't know if you're familiar with cognitive therapy. That's what we were calling it in those days. This was about 10 years back, before T.E.A.M had emerged. And then she started like swearing at me and saying she'd heard of cognitive therapy and it's a bunch of BS, and where did I get off, and I could go screw myself. And, really I felt humiliated, and she was just livid with rage. I thought, well, I don't think I'm going to work with her in the group today. She doesn't seem like she wants help. And so I worked with a woman on the opposite side of the table. We were seated at a big round table, about 12.
So you ended up not working with her?
No, I was terrified of her, and she clearly didn't want help. Yeah. And this other woman had a similar thought. I worked with her, but all during the group I could feel the hatred coming to me from this patient. I was afraid even to look at her.
The evil vibe.
Yeah, that's right. And but this other woman was very responsive, and we had an excellent group. And then they fill out the end of session ratings, and I hate to look at it when I know it's going to be bad, but I forced myself to. And so I tremblingly got this woman's feedback, who had been shouting at me at the beginning of the group. And I was shocked when I looked at it, because all of the mood things had gone to 0.
Oh, so it worked.
Well, I hadn't been working with her. She was just sitting there hating me, I thought. And I turned it over, and empathy was a perfect score. Helpfulness was a perfect score. And then at the bottom, the patients write out, was there anything that turned you off during the group, or that you disagreed with? And she put the word nothing. And I said, was there anything you liked or was helpful? And she said, Dear Dr. Burns, at the beginning of the group, I was so angry and devastated. But when you worked with that other woman, I felt like you were working with me. And I've never heard of cognitive distortions before. I always thought it was that I was a bad person, and I'd never heard of all or nothing thinking or should statements or self-blame or overgeneralizations. Yeah. And to tell you the truth, my depression has disappeared for the first time in my life. This is the first happiness I've ever experienced since I was born. God bless you, Dr.
But you had
Burns.
no idea until you got the feedback.
Until I read that. And if I hadn't gotten that feedback, I would have avoided her on the unit. I wouldn't have wanted to look at her or be close to her. Yeah. And those are severe examples of a phenomenon that happens with therapists all the time in clinical practice. You think you know how your patients are feeling, but you don't. Your accuracy is not up there. And on the positive side, if you're willing to begin to use some kind of assessment scale, it can transform your clinical work, because the system we use is like an emotional X-ray machine.
Now, I hear that, and I know that it's true, but I think that a number of therapists listening to this may go, no, I know my patients really well, and that doesn't apply to me.
Yeah.
Well, what would you say to those people?
Well, God bless you, and at some point you want to give it a try. You might do the experiment of give the brief mood survey to 20 patients in a row that you see in a week, and have them, don't do the before session testing like we do, just have them fill it out at the end of the session.
Okay.
And fill it out yourself and estimate, your understanding of how the patient is feeling at this moment, and then look at the correlation. And I think you'll see it's the same as what I saw in my study at Stanford, that your perceptions just are not accurate. And that has tremendous clinical implications. Not only does having the information allow you to fine-tune your work. See, if I'm working with you and you're not being helped, I don't care, because I've got so many techniques and so many ways to shift gears that if we're not on track, then I can get back on track with you. But I have to know it, and I have to have the humility and courage to look at that. The same is true in teaching as well. And maybe our radio broadcast will get feedback from people, what they like and what they don't like. But
now,
go ahead.
You're talking about people trying this out for themselves, like therapists trying this out for themselves. But what is this brief mood survey you keep referring to? Where is that?
Okay. Well, it's a single piece of paper. Therapists who are interested in using it, I'm not trying to sell my tools so much, but just the concept of measurement. There's a lot of tools out there competing for therapists' attention, but in I market a therapist toolkit to therapists that has hundreds of pages of psychological tests and treatment tools that therapists can photocopy and use for the rest of your life. Once you buy a toolkit, it's free, so you don't have to be paying these royalty fees. And the brief mood survey, the generic one, there's 70 psychological tests in there, but it's one piece of paper printed on both sides, and on the front side, it's depression, suicide, anger, anxiety, and either positive feelings or relationship satisfaction before session and after session.
Okay.
And then when you turn it over, there's the 5-item empathy scale that they fill out after the session, the 5-item helpfulness scale, satisfaction with the session, if they had negative feelings during the session, and a scale for how honest they were in filling out the survey, and then they can also write at the bottom what they disliked and liked. And so you as a therapist can suddenly pick that up. They leave in the waiting room, they go home, you pick it up, and you can see exactly how you did in all of these different dimensions and address those issues when you see the patient the next time.
David, something I was thinking, since you were doing that study with the psychiatry department, psychiatrists are MDs, and when I go to see a doctor, one of the things that they do, probably the first thing they do, is they take my pulse, my blood pressure, my temperature, and this is kind of like a routine thing for me when I go see a doctor.
Absolutely.
Now, I've gone to therapists myself many times. I've never experienced that.
Yeah. One of my classmates in the residency program at Penn in the 70s was John Rush. And he went his separate way. He went more into biological psychiatry, although he was the first author on the first cognitive therapy outcome study that was done. But he presented a grand rounds at the Stanford Department of Psychiatry just a few months back, and he coincidentally has gotten into the same thing that I've gotten into, is measurement and testing. And he was speaking from the biological perspective, not the psychotherapy perspective. Mm-hmm. But he was arguing that psychiatry and psychology are measurement-free zones. That we're not measuring anything the way you do in the rest of medicine and the way you do in science, and that it's not right. And he was showing how, even if you're prescribing medications, how this simple assessment test every session can really revolutionize clinical practice. And I'm totally in agreement with that. And I sometimes say to people in workshops, if how many of you require your patients to take at least one psychological test between every single therapy session as a minimum requirement if they're going to see you?
Probably nobody.
Well, it's generally 1 out of 100 or 1 out of 200, something, very few. If they've been to a previous workshop of mine, a few hands will go up, but it's very, very few. And then I say, if you had pneumonia and a burning fever and coughing up blood and phlegm and shakes, and how many of you would go to a medical doctor who didn't believe in the use of the thermometer, X-ray, blood test, and no hands go up? And I say, well, you've got a kind of double standard going. When you're the patient, you demand the doctor use the scientific method. The history is important, the physical exam is important, but you want that doctor to be guided by sound lab tests. But when you're the therapist, you're kind of flying by the seat of your pants. And I think in the old days you could get away with it, but I think as we move into the future, that this is going to be required of mental health professionals. But aside from that issue, I think you can do yourself and your patients a tremendous favor by beginning to use either the type of assessment tests I've developed, which I think are state-of-the-art, really, or any assessments that you think will be suitable for your clinical practice.
Well, this brings up a question, and this may be a little bit beyond the pale here, but since, as therapists, we, in a way, work with the brain. We're not brain surgeons, but why don't we go and look inside, like do some kind of imaging, or I don't know. That would seem like the thing to do, since we're about healing the brain in a sort of way.
Yeah, people get really, really excited about brain scans, thinking this is somehow making things more scientific, and certainly brain imaging is a good tool for research. I'm not aware of any valid clinical uses at this point of any type of brain scanning. What you're really looking at is blood flow in the brain, patterns of blood flow, activation of different brain regions. But take my depression test is 0.95 accurate. It's 95% accurate. It can be completed in 15 seconds, and the cost would be a penny, for the piece of paper that you've photocopied it on, and that's going to be an accurate showing you how the patient is feeling inside. Brain scans will not be giving you that information. Brain scans don't go too much beyond right now telling us simply that the brain exists and that it does different stuff. But brain scans can't tell us what's normal or what's abnormal in psychiatry, and they can't also they can't be used to track clinical progress or to make diagnoses.
Well, we may have to bring in a neurologist guest at some point for the two of you to debate this.
I don't think there would be a debate. I think the top brain imaging people would agree. In fact, I work with some of them and do statistics for some of the brain research people at Stanford, and they say, I'm really quoting them in this regard, that there are really no clinical need for brain scan. But I started out in brain research, and I'm excited about the future of brain research. But I think right now people are kind of getting ahead of the curve. The same thing happened around the turn of the 20th century, about 1900 to 1910. Phrenology was big at the time.
Yeah.
And people thought by the shape of the head we can see personality patterns, and people read all kinds of things into that, got all excited about it. But I don't mean to be critical of neuroscience. I've done a lot of neuroscience, and I'm excited about neuroscience, but I think we sometimes oversell things.
Okay. Well, that sounds like a good place to wrap up. One thing I wanted to add is that I have used some of your testing tools myself in my practice, and I have to say that the one that seems to work really well for me is the after-session evaluation, because I get to see how the session was received by the patient, and when there's a deviation some weeks, that gives me something to really bring into the session the next time, and I found that really valuable.
Yeah, I know you are a great clinician, Fabrice, and have beautiful empathy skills and therapeutic skills, and I know that you're getting on the empathy scale perfect scores much of the time, if not most of the time, from your patients, which is great. Sometimes when therapists hear about these tools, they think, "Oh, my patients won't be honest with me. They'll just tell me what they think."
That's what I used to think in the beginning, though.
Yeah.
They're just going to want to be nice.
Yeah, but it turns out the opposite is true. When most clinicians, like people listening to this podcast, use my scale for the first time clinically, they report getting at least 50% failing grades on the empathy scale from 50% of all their sessions, and most report getting failing grades on every scale from every patient at every session. So this can be a bit of a shock to the system. The problem isn't your patients won't be honest. The problem is your patients will be honest.
Which I see that as a positive.
Oh, yeah, yeah.
Then you get a chance to do repair if you need to.
Absolutely. If you set your ego aside, it can be a tremendous opportunity for learning. But we all have a sense of pride, a sense of shame, and it can be painful to get to use these scales and to suddenly see the truth for the first time. But if you have the courage, it can transform your clinical practice.
Well, I hope that some people out there decide to try this out and see if it can actually change their clinical practice. If I'm right, in some of your books, like Feeling Good or When Panic Attacks, you describe some of those instruments.
Yeah, people are interested. You can see, Feeling Good, the Feeling Good Handbook, When Panic Attacks, the 10 Days of Self-Esteem. You can see some of the earlier versions of these scales, kind of how they're set up. They're in 4th grade to 5th grade language. They're user-friendly. They're real easy to take. Therapists with a serious interest might want to go to my website, feelinggood.com, and take a look at the order form for the therapist toolkit.
Right.
Because if you get a toolkit, then you're licensed to reproduce all of these assessment and treatment tools for the rest of your life without having to pay royalties. So that's just one option to check out. There's a lot of psychological tests that people can use in clinical settings.
And, I'm aware myself of other instruments that do not, come from your model, but Scott Miller, I think, has published some instruments that also do this type of measurement.
Oh, absolutely, and I applaud what he's doing. I gave a talk at the Evolution of Psychotherapy conference a couple years back, and then they had this little autograph table where you sign books, And this fellow came up to the table and said, "Oh, can I get your autograph?" And he says, "I've been a fan of yours. When I was doing my internship in clinical psychology, I used all your scales, and it just transformed my clinical career, and you're one of my heroes." And I said, "Oh, that's great. I'm glad to meet you. What's your name?" He says, "Oh, I'm Scott Miller." So he's definitely picked up on that, and I totally support his efforts. He's promoting the gospel as well.
Yeah, so I think that's wonderful, and there's more than one way to skin the cat.
Yep.
I hope Hobie is not listening.
Yeah.
All right. Well, David, I think that was a very enlightening session, and I think next time we'll be talking about the empathy part, right?
Fantastic.
But we'll close for today, and people can go to your website if they want to know more, feelinggood.com. So thank you very much for talking with us today.
Thank you.
Bye-bye.